Hello, everybody, and welcome to Charlie Mike, hosted by me, Mike Buchanan. Hey, listen, today we are finally ending our entire month of Mental Health Awareness Month. So today we have the boss of mental health here for all of North Texas, and he's going to be talking to us kind of about the mental health programming at VA North Texas, as well as some of the experiences of just basically being the boss. Like, what is it like to be in charge of a mental health facility that's this big? Because honestly, I don't know if any of you out there knew it, but we're considered the largest mental health facility in the entire United States. I didn't know if you knew that, but correct. Now you know that. So a little trivia question that you can share with your friends, I guess, if you're ever talking VA trivia, which if you are, you're lame. So other than that, hey, welcome, Dr. Bender. So this is Dr. Stephen Bender. So this is your camera, Dr. Bender. So okay. If I say something stupid, by all means, this is your golden opportunity. This is it. That's right. This is your golden opportunity to make me feel dumb on camera and immortalized. Okay. Some people take advantage of it. I know Rodney Teague definitely took advantage of it. Or Dr. Teague. He definitely took advantage of the camera. He loved it. The camera loved him, so it was good. And you are the chief of mental health care for the VA North Texas healthcare system. Correct me if I was wrong.
No, that's correct.
Okay.
I am a psychologist by training. I've had the pleasure of working at VA North Texas for almost 16 years now, and am newly the chief of mental health. So I've been in that role less than a year, about 8 months.
Yeah. Well, thank you so much for doing the podcast. I really do appreciate it. You're right. You are new to this position. Your predecessor and I were frenemies, so that was good. But it's okay. God love her. She did what she could. But everybody has mental health is really hard. It's a really hard thing to be in charge of. I only imagine, honestly, because I mean, everyone has such differing opinions, and mental health field is changing so rapidly all of the time that sometimes it has to look like no matter how much you work, are you ever really catching up? Does it ever feel like that?
Well, it has challenges. I think that's a good point. I mean, and as you mentioned, we are the largest. We can talk even more about that in terms of veterans we serve. But it has a lot of challenges. I think for me, it is, even with those challenges, it's an honor, something that I haven't forgotten on a daily basis, to be able to be the chief and to run and oversee those things, even in the difficulties. For me, I got into this field and then particularly to work for the VA for a very specific reason, and that was a passion for wanting to serve or give back and reach veterans, and that's the population I wanted to serve. Many of our staff have the very same mentality or reason in mind. So even when we do face significant challenges and need to keep up and stay afront and address things that happen when you are the largest, there's many pluses to that, but there are some challenges to that. I don't think we ever lose sight of the mission that we have and what an honor it is to serve in this facility.
Well, I guess that brings us to this. Why don't you tell us a little bit about yourself?
Sure. Like I mentioned, I am a psychologist by training. I grew up in West Texas, in Odessa, Texas.
In the desert.
In the desert. In the desert. And decided, if you ever, I don't know if you've been there.
I have.
Yeah. So for me, growing up there, I decided after high school, wanted to get as far away there as I possibly could. So I went to college and grad school in Virginia and then on the East Coast, and then came back to Texas A&M for my graduate degree, and ended up residing here in Texas. My early training in the field of psychology was with children. It was with children in PTSD or trauma. And it was after 9/11 that I had a cousin who served. She was in a support role, not in a combat role, but served a couple of tours. And I was moved by that experience, like many others that I know, and thought about, is there a way that I can help or serve in some way? So I was working in Fort Worth and reached out because I saw some opportunities at our Fort Worth clinic, and I ended up applying and didn't get that job. I got a job at our Bonham clinic and worked there in Bonham for 9 years as a frontline psychologist, and then became the clinical director there in Bonham, and then moved up to Dallas as the chief of psychology, the deputy chief, and now the chief of the service.
So you started in the boonies, and then you came back to the boonies.
Yes.
So they sent you out to Bonham, which is the boonies.
You're right.
Yeah.
You're right.
That's great.
I have a wife of, I got to get this right because it's coming up this Sunday.
Oh,
18 years is our anniversary this Sunday, and 3 kids. They're all teenagers now. My youngest son just turned 11. Then I have 2 daughters that are 16 and 15.
Oh, nice. Yeah, all of mine. I have 2 boys. Both of them are teenagers. One of them just turned 13. Let me get this right. 2 days ago.
Oh,
so
happy birthday.
Yeah. All right. So let me ask you this. Let's start off with this question. So what is mental health? What is our mental health program, right, really doing for veterans today, and kind of what are we going to be doing for them tomorrow? So what do I mean by that, right? So we are the largest mental health facility in the entire United States. So we have to be doing something for veterans, obviously, right? And I would assume that we're doing quite a bit for veterans and different modalities or different kind of methodologies of what we're providing here. So let's talk about some of those that we're providing for veterans. And then maybe let's kind of dip into maybe some of the ones that we're really thinking about kind of doing for veterans.
Yes. And let's talk about, I think it's important to talk about what we mean when we say the largest VA. It really is by unique veterans that we serve.
Yes.
So for us, that is now over 40,000, somewhere around 40,500 in fiscal year 21, and we expect that to go higher in fiscal year 22. That is a lot of veterans who come to seek care with us and entrust us with their mental health care. It is a large responsibility and requires a lot of services that we offer. So we are large and complex and really offer the full spectrum of mental health care. We can start with the kind of the higher acute levels. So we have a mental health acute inpatient unit. Those are, of course, for people who are at imminent risk of harming themselves or others, feeling psychiatrically unstable in a level that they're not safe. We have a place for them to come and spend some time with us, focused on helping them retain their stability and get back integrated back into the community once they feel safe again. We kind of go down to another level of care, which would be residential care. So we have, we're gifted in this way in terms of options for people who need residential treatment in several different ways. We have residential treatment for veterans dealing with substance use disorders. And we have that on 2 campuses, both on our Dallas campus and then on our Bonham campus, with quite a number of beds. We have residential treatment for veterans dealing with PTSD specifically, and then we have residential treatment for veterans who are dealing with homelessness, who need a chance with us to get back on their feet, to work at some job reintegration skills, to work on some plans for housing options, and we partner with them, work with them to get them back into the community, into a secure housing environment. Then we have the full spectrum of outpatient mental health care. In many ways, that is, providing the kinds of things that you think about: psychiatric medication management, psychotherapy services, individual types of services, group types of services, all at all of our locations, at Dallas, of course, but then all of our community-based outpatient clinics. We have a large number of staff that are providing those outpatient services. Among those, then, there's specialized programs. So of those outpatient services, we have teams that specialize on the geriatric population and older. It may be a surprise to some, but one of our most prominent diagnoses is memory problems, cognitive disorders. That happens quite a bit. So it includes depression and PTSD, but memory problems, cognitive issues are quite high on our list as well. We have a specialty team for geriatrics. We have a specialty team focused on trauma, on PTSD and MST, which I know that you've featured. Mm-hmm. We have specialty programs that focus on other kinds of diagnoses, like anxiety or obsessive compulsive disorders, those kinds of things too. The full kinds of diagnosis or spectrum that you might be experiencing, we've got teams on an outpatient basis that can help and treat those things. We have some specialty programs also for veterans with other kinds of diagnoses, what we call seriously mentally ill or psychiatric diagnoses, like schizoaffective disorder, schizophrenia, severe bipolar disorder, or borderline personality disorder. We have a program called our Psychosocial Rehabilitation and Recovery Center.
The PRRC.
The PRRC, yes. And they come and spend time with us. So it's a little bit more frequent. Some of our outpatient services might be weekly or every other week, or you might come back for medicine every 3 months or so. For the PRRC, you come more frequently for a period of time. It's almost like a semester of college, if you will. You sign up for certain classes, both group and some individual support. You do that both on campus with us, and there is increasingly, we were hampered a little bit with COVID, but as we move out of that, it's focused on community reintegration. So there is traveling and doing some things out in the community to help them get more comfortable out in the community and building social skills and the other kind of skills they need to recover and live comfortably and meet their goals. We have another program for veterans who need more, who might be facing those serious mental illnesses, and they need more than just weekly types of care visits, and they may need us to go to them. So we have a team of social workers, nurses that will go to their location, either their apartment, in some cases a group home, wherever their family home. We'll go to their site to deliver medicine, to check on them, to help them with all aspects of their care as well. MICM, or I think it's, you know how these change frequently.
Of course.
I think it's ICMHR now, but we still say MICM.
MICM sounds so much better.
The other thing I should mention, a huge, we have over 650 staff. I think something like 150 plus of those are dedicated to a program I haven't talked about yet much, except for one of our homeless domiciliary programs, but we have a whole group of staff that are focused on homelessness. A huge group of staff. So that includes staff in Dallas, staff in Fort Worth, and then they're spread out in certain places throughout the Metroplex, focused on reaching veterans who are homeless or who are at risk of being homeless. In all sorts of ways, trying to help them where they are, trying to help them get emergency shelter, trying to help them get into more long-term shelter, and then ultimately get into stable housing.
Yeah.
And a team of people who do that both on campus, and a lot of them work out in the community. So they're going out regularly and doing even therapy groups at the homes where these veterans are. We contract with some homes so that we have specific beds for veterans at certain shelters. So we know that we have the space, and we provide support there, go to them, and then work with them where they are. Another big chunk of what we offer or do.
That's a lot.
It's a lot, and I haven't mentioned it all.
I know you haven't even mentioned it at all. Yeah. So I will just talk to the camera then. You say we don't do anything mental health related. You're full of it. I mean, honestly, that's a ton. That's a ton of programs. And like, to me, I wouldn't even think that some of those programs really should fall under mental health, but like, it's crazy that some of them do. Like, some of them I totally understand, like MICM, obviously, right? Like, you're dealing with intensive mental health treatment, problems, right? So you're dealing with intensive mental health problems, and you're trying to reintegrate them back into society, right? But like things like the homeless program, right? To me, like that screams social work, right? Doesn't it? Doesn't it like scream social work? Because I mean, most of those 150 people that work there are social workers.
Yeah,
most of them.
It's a huge chunk of them.
But it's crazy that it's covered under mental health too.
Yeah, I think we see it as another value of us.
Sure.
And we were aligned. You've probably heard that before, and I'm sure veterans who have been who have traveled or have lived in different places realize that VAs are different from one VA to another. Certainly, that is true in the way they're organized, and even the way homeless programs and other programs are organized. We love being all under one umbrella. There's ways in which it helps us in terms of coordinating care, communicating with each other, and you can imagine, I mean, oftentimes people who are dealing with homelessness, there are ways in which they need and more mental health support or be connected to outpatient or other kinds of these specialty programs. It makes it easier and more seamless for us when we're all one big family and connected in that way.
Yeah, we've talked about it a lot on this podcast. Honestly, I've talked about product line versus service line and kind of what it looks like to have a product line and what it looks like to have a service line. So ours is more, I guess, would be a product line, right? So that's like correct. If there's mental health involved in it in some way, that's kind of the product, right? The final product. And so we manage everything that has a mental health attached to it as the final product, right? And so a service line would be anything that just includes that service line of workers, right, is typically. And so some VAs work service line, some VAs work product line. And so I've explained that before on the podcast.
Okay, yeah, that's exactly right. That where those service lines would be all psychology is one service, all social workers one service, all psychiatry, where we're all under one umbrella.
Yeah, exactly. Okay, great. That's a lot. Dang, that's a lot. What is it? Let me just ask you this before we get into like really the next like major question, but like, what is it like managing that many services? I mean, because like I know like you have managers for everything. You have middle managers, obviously, like that manage all these different programming, but ultimately it all comes down to you. I mean, ultimately, right? I mean, like that's got to be rough sometimes.
Of course, it has challenges. I mean, I do want to say, even with that, I recognize the opportunity that I get, and I am grateful for that. And that's part of what I'm supposed to do. I'm supposed to be the one that bears the responsibility, that answers and helps support in the challenges. I really do need for my frontline staff to do the best work that they can do. I mean, our goal or our mission, of course, is to provide exceptional mental health care to the veterans we serve. From my role, when I'm hiring and leading people that work for us in the mental health service, I know that the best way to get them to provide exceptional mental health care is to hire great people and to treat them well. They need to be freed up to do what they do and do it well and enjoy doing it. So that's what they've got to spend their time doing. My job is then to help lead them in ways to help deal with barriers that they might face, to help work on other kinds of things that we need to advocate for in terms of changes or money or budget issues to get more staff, or things that need to be addressed when there are concerns or problems. That's what I'm here for. That's what I'm supposed to do. And again, it is an honor and a privilege to be able to do it. It does have its challenges. Sometimes they're harder than others, but I'm very grateful.
I'm one of his challenges. If you didn't catch that, I'm very passionate about what I do, and I'm very passionate about the things that I care about. And so sometimes I'm a little too passionate. So
I would describe you that way. And it's the other piece that we need. We need people who are willing to express their opinions, to be honest with us about things. As I mentioned, it is an honor or a privilege, and there's some things I mean by that. When you think about the number of 40,000 veterans entrust us with their mental health care, and what that means for somebody. I know that you've discussed in other podcasts about the stigma of mental health in our society. Even it's getting better, I hope. I think we're a part of that in the VA and other places. Destigmatizing that. I think with COVID, there's been more of a light on mental health issues and encouraging people to get mental health help and support. But I know in particular in my work with veterans and with military experience that it's still very difficult. I know personally to decide to go to someone and sit before them and say, I have a problem and I need help. And then I have to talk about what that is a very vulnerable place to be. We are so grateful that they're willing to take that step and do that with us. It's not lost on us of what that takes for them to take that step with us. I think the other thing we know very clearly is we can help facilitate those kinds of things, but we're not the ones that bring about the change. It really is a strength within them, and their willingness to come and participate and then follow through. Then we see real change or progress. It takes a real strength.
You mentioned COVID. So I think before COVID, I think people were just kind of maintaining. I think because here's the thing: when my kids asked me, I talked about this too. I talked about a lot of things on here, but my kids asked me one time, how many people do you think have mental health problems? And I said 100%. I mean, like 100% of us have mental health issues sometimes, right? Like we have mental wellness issues. Let's put it that way, right? Your problem may not be as exorbitant as some of these other problems can be, but like you still could benefit from talking to someone about whatever's going on, right? To manage stress, to manage expectations, to manage a lot of different things. And I think that before COVID, everyone was really kind of like had their own kind of system of managing all that. And then COVID just kind of messed all that up. And then there was a lot more people out there that were like, oh yeah, crap, maybe I do have some stuff going on. So maybe I should, instead of keep telling or advocating for people to go and talk to someone about it, maybe I need to start talking to someone about it. I think it was that huge, I don't know, it's a huge change. It was just like a tsunami wave.
Yeah, no, I agree with that somewhere. It just added so much stress or change or newness that we never faced before.
Isolation.
For many people, that was enough to say, I got to do something or get help. But the other point I like what you're saying there, Mike, is, and I think it's important to bring out because I mentioned diagnoses or class of diagnoses, and that's true for many people. But you're right. It may not be at all for you to come get mental health support. Doesn't necessarily mean we're going to diagnose you with anxiety or depression or PTSD. It may be a situational issue, that you are going through some job stress, you're going through some marital stress or relationship stress, some other kind of thing in your life, and it is helpful to come to us. It doesn't mean necessarily that it's going to need medicine. It doesn't mean that you're going to have to come to mental health for the rest of your life. The exciting news for many that we have to offer is that we can help through mental health, and it often doesn't mean lengthy kinds of commitments. Some, want to come as long as it takes. Others, it's really hard to get them in the door. And they would say to me, okay, how long do I got to be here? How many visits is this going to take? And there isn't a total guarantee about that. But in many cases, there's a lot we can do in a shorter amount of time, where they were worried that they were going to have to come and, commit weekly for the rest of their lives. That's really not the case. In many cases, veterans find they come with us. We see each other over the course of 12 or 15 sessions. That might be 3 or 4 months. And there's a lot of great things that can happen then, where people feel better. Sometimes they decide to stay with us. Sometimes they come back and just check in every once in a while. Or if they face a stressor later on, we're here to be supportive in that way. But you're right. It doesn't have to be, something that necessarily is on the level of a serious psychiatric diagnosis. We're here to treat those too, but it's the full spectrum and can be any kind of thing that you face where you need support.
Yeah, Rodney Teague said it best. I think he talked about, he wished that it wasn't so much about mental health and wellness, but it was more just about mental wellness in general. Absolutely. Right? He's like, we always focus on serious mental illnesses and SMIs, or we're focused, especially veterans, right? Veterans, we focus on the big problems, right? The TBI, PTSD, MST, and that's pretty much it, right? I mean, and drugs and alcohol, okay? Because we usually have drugs and alcohol problems. But like, we're focused on these big items, these big ticket items. But there's so many other little tiny items that I think that we just never even delve into, right? Because I think that it's just, I don't know. I mean, it's really, maybe it's a little bit VA's fault. Maybe it's a little bit of veterans' fault, right? But I think that we need to focus more on our wellness rather than how sick can we be. I know it's controversial, so you don't have to answer.
No, it's true. It's about wellness.
But I think the VA focuses on really, if you think about veterans, right? We focus on how sick are we, right? Everyone's always asking you, like, what's your service connection? Because how sick are you, yeah. Right? And it's like, it's really, as the VA employee, I know that we want to focus more on how well can we have you and how excited can you be about being well, instead of how excited can you be about being sick because you get paid more money, kind of thing, if that makes sense.
I do, and I've had interesting discussions too with veterans who were very reluctant to come in to get help, and then would often kind of say this thing that, Is
it going to change my rating?
Well, no. It was a generous thing. Like, I'm worried I'm taking a spot of somebody who needs this more than me.
Oh, have you ever heard my explanation for that? Listen. No. Okay, so look, they're line theorists. Mm-hmm. Okay, that's what they're called. I call them a line theorist. It comes from a long line of military isms, but it's a chow line. So in the military, when you eat food, the NCOs and the officers, the people in charge, so you as the chief would eat very, very last. Okay, every one of your employees would eat first. Mm-hmm. You would eat last if there's food left. Mm-hmm. Like, only if there's food left. And if there's not, you don't eat. Right? Because they're the ones doing all the work. You're the one just supervising the work. So you work less, you use less energy. In the military, that's how it goes. You use less energy, you eat less energy, okay? You get to consume less energy. And so they all think of it like a line. It's like a public, like a line, right? But it's not a child line. It's more like a public pool, right? So you go to a public pool, you go, okay, it's really crowded, but I think I can fit into that corner right there. And then you go to that corner and then you jump in. That's what I tell people. The VA is like, it's not a chow line.
It's not a chow line.
It's a public pool.
And they're you deserve the treatment as well.
Yes.
You deserve the treatment as well. So
you earned it. Yeah. You absolutely earned it, right? Absolutely. I hate when people tell me that they're entitled to it, because you're not entitled to anything. I'll say it. I don't care. And I've said it before on this podcast. Unless you're a king, a queen, a princess, a princess, a lord, a lady, a duke, a duchess, a baron, or a baroness, you're not entitled to anything. But you are very deserving of the things that you have earned. We earned these benefits. Absolutely. And we're very deserving of them, but no, we're not entitled to them.
There's room, regardless of the kinds of situation or symptoms. If you have some struggles or concerns, there's room for you. Our job is to be able to provide you treatment and to help you in that way. And we have it. We can do it.
Awesome. Let's get back into it. I'm sorry. I segue a lot. My bad. You're going to have to follow my weird train of thought. Let's talk about this real quick, because this is a question that's kind of been on my mind. And so, I guess another segue. But we talked about some of these services, okay? We talked about a lot of these services. Let's talk about this. How does one get connected with these services, and what does it look like in different VAs? Because I know it's not as consistent kind of across the board, well, I'm sure that you'll tell, for instance. But so how does a veteran get connected to these services, right? And then if we'll get into the next question. The next question is going to be a lot better. But how does someone get connected to these services?
Yeah, I don't want to sound general here, but I want to start that way. That
Okay.
I do think, we have a large mental health service, so it really just starts with them coming in and asking. In many cases, for veterans, it can be their primary care provider, or if they're already there for some other service, their primary care provider very much knows how to refer or connect them to mental health. We have a system in place to do that. In many cases, that can be done that day if the veteran wants it. There is either a clinician on site available to come to them or to come get them and take them to an office from their primary care provider. Sometimes it can be done by phone call if that makes them more comfortable, even now by video. But that's one of the best ways to get access. You can also then just come in and ask for a mental health appointment or mental health services at all of our larger clinics or any campus where we have mental health presence on site. It's easy to make that happen and get connected or schedule an appointment. If there is an urgent need or screen, that can be done there. In some cases where we don't have mental health on site, then the clinicians there will send information to mental health, and mental health will respond with a phone call to connect or follow up with that care. In general, we have what we call primary care mental health access or mental health integration clinics. We used to just call them access. That was sort of the first point of line. Mm-hmm. So if, I know we have a lot of acronyms, and you were mentioning others.
Tons of them.
That's PCMHI. Again, you can just call it access. Most people that here at RVA know what that is. And that is that clinic that is connected to primary care. But you don't have to. We don't want you to feel like you've got to see primary care first. If you have a mental health need, we don't want any barriers to be that. You can just come and present at the Access Clinic or Primary Care Mental Health Integration.
Okay. And there's number 2, right?
There is a number.
You can get it out. I know. I told him I was going to ask him this question, so he's like, "Oh, I got this number on my phone." I was like, "You don't have to memorize it. It's okay."
It's 214-857-4279. And that is a general number for mental health on our Dallas campus, but it covers all the campuses. So one of the things we've done recently, given feedback, is we have coordinated care across all of our primary care mental health integration teams so that they're following similar procedures and protocol, and they really have one leadership and connection. It does a lot of things for us. If a certain site has a staffing issue, or maybe a staff member that had to be unexpectedly out that day, we now, it's all one team. So we have clinicians at other sites that can provide support at that site or drive their help in a way. So if you call that number, you'll get a menu. It'll mention to you if you know your team assignment. So it'll mention if you want to reach primary care and mental health integration. It also says access on the voice. Then you just press that number. It'll also ask you if you don't know what mental health team you're assigned to. It'll give you a number to press. Press that number. You'll be connected with somebody, and they'll get you connected to a clinician who will call you and set up an appointment.
Awesome. About how long do you think that it takes to hear back, or how long should it take?
Well, we want it to be quick.
Sure.
Part of what our goal is always is to be able to, if there is an urgent need, to be able to do that same day and see them. Sometimes that is a triage appointment, something that is a little bit shorter, checking in and making sure. For example, if the veteran is in significant crisis and we're concerned about, and they're concerned about risks to themselves or others, we want to address that immediately and help get them safe. So we will check in and ask them questions if they come in that regard, and then plan with them about what they need. If it isn't then an urgent issue like that and they want to get connected to services, our goal is to reach them and be able to set up an appointment in 20 days. If we're not able to do that, then we sometimes the veteran doesn't want to do it, and they have something in mind that they want to do it a little bit later than that, we can always accommodate that, of course. We have options now through the Mission Act and Community Care that we can partner with Community Care if we're not able to do it timely and send them to a community provider. There are some challenges I should mention with that.
Sure.
In our larger areas, in the Metroplex, in some of the more populated areas, it's easier for us to find community providers that we can access and get them timely appointments. In some of our broader areas or more rural areas, there's a lack of mental health providers in those areas as well. So it's a little bit more challenging. There might be, and we negotiate that or talk to the veteran about that.
Yeah, let's talk about that real quick. Just because I just wanted to kind of say this across the board, because it's something that veterans really don't understand, the whole community care thing and how it really works. I don't really realize, I guess, are we covered, is mental health covered under general 30 days or is it covered under specialty care? Or is it considered specialty care? Okay, so 60 days, right? So we have about, is it 45 or 60 days to comply?
Well, it's here's what I know about community care for specialty care.
It's 30 days,
30-minute drive time, 20 days.
20 days.
Yes.
Oh, you're even less days. You're even working on less days than
exactly. Yeah, it's meant to get you in sooner, not
okay,
later.
so I think, yeah, you're right. And so it was primary care was 15 days. I think we had to get an appointment for veterans within 15 days. I thought that specialty care was like 30 days, 30 or when it first started, when the whole Mission Act first started, it was like 30 to 45 days we had to comply with, certain, we had time criteria, basically is what I'm trying to say. We had a time crunch criteria that we had to kind of meet. And if we couldn't meet that, then we needed to refer outside. Correct?
That's correct.
Okay.
If that's what the veteran wanted.
Yes.
To offer that.
Exactly. Yeah. If that's what they wanted. But veterans were also like, okay, well, I have this place down the street, blah, 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 that's totally willing to see veterans. Here's the thing. Let's talk about that real quick. Because I answer this question a lot, so I might as well just I might as well immortalize the answer. Okay. Community care doesn't work like that. They have to be worthy of taking care of you as a veteran. They go through a strenuous process. The VA goes through a strenuous process to go and figure out a location first and foremost. Once they figure out that location, they have to go through all these tests and procedures and visits and follow-ups and all sorts of paperwork to become a facility that's good enough to treat you as a veteran. And that's the VA standard. And our standard is way higher, okay, than most of your regular civilian standards, because our marketing, that's what I tell everybody, because our marketing department doesn't have that much to cover up bad things. So we have to make sure that it's very, very good so that we don't have bad press, because honestly, we can do bad all by ourselves. So thank you very much. But I just wanted to kind of explain kind of why it, because veterans are like, well, I want to go out in the community for everything. Well, it's not that simple. There's rules to follow. There's stipulations that we need to follow, right?
Yeah,
and we have to make sure you're getting the best care possible. And sometimes I know you feel like the outside might be the best care possible, but because it's more convenient, convenience doesn't make it best.
You're right, and I do recognize. I mean, one thing you were alluding to earlier is the rules have changed over the years. Yep. So that is true, and sometimes that's difficult to keep up with. Right now, those rules for us in terms of mental health, particularly outpatient care, we'll talk about another option. Mm-hmm. But outpatient care is if the drive time is greater than 30 minutes, or if we can't get you an appointment within 20 days. You're right, though. Then there's a process that involves other services and even a third-party provider in that step. It's gotten better over time, especially in the areas where we have private providers enrolled in the network that they can get scheduled with and work with. Sometimes veterans do have a provider in mind. They will explain that to the third-party provider, and the third party can look and see if they're connected in the network. Sometimes they can even talk to them about the process for that provider to get enrolled in the network. As you mentioned, it might not always happen. There are some standards that have to be done or followed there, but they'll try to work with those things if they can.
Sure.
But it might not always be. And sometimes there are mistakes there. I was dealing with a veteran recently who they were coming to us. It was a wait time issue, not a drive time issue, but they got a sooner appointment, but it was way far away from where they lived, and so I helped connect them back to the third-party provider. In this case, we were now had a window that we could see them sooner, or we could partner if they wanted to see if community care could, in closer location to them. But sometimes there are those challenges that happen.
Sure.
We should mention the rules for residential care are a little bit different. That also has sometimes we've run into questions from veterans or from often residential care facilities themselves. I think that that's gotten better, been more clear over time, but our rules for that are a little bit different. They're not guided under the Mission Act, but we do have a directive that guides us in that policy, and that is a 30-day window. So two things. If there is an emergent need for residential care, that then we can consider, it opens the door for us to work with or potentially consider community care if needed. The next is if we can't get them in with us in 30 days, then there are some steps that we have to follow in order to authorize community care. The first step is if we can't, then we need to look at another program within our VISN or within the VA. We do have some in our region in Waco and Big Spring. We have worked with them sometimes for availability and to coordinate transportation. And they have sometimes had availability sooner than we've had availability. Then if we can't do that, we consider either alternate levels of care or sending to community care. Sometimes there have been situations where a veteran has just enrolled or started at a private facility of care and then contacted us for help. Usually that's not the best idea. The best way is to, communicate with us first or your mental health team or your provider and then discuss options. But the rules are a little different there for us, and we're navigating those pieces.
You said it so nice. It's not a great idea to just go somewhere and think the VA is going to pay for it. Don't do that. So there you go. I said it much more direct. Don't do that. Yeah. It's not a smart idea. You'll probably be paying your bill. Please don't do that. It's just like with the emergency room. That one's always been tricky, though. Like, it's hard. The emergency room, I totally understand. But the emergency room, it's always been this huge fight with veterans, right? It's like, if I need to go to the emergency room, do I need to tell the VA first, or I need to just go to the emergency room? You go to the emergency room, right? Hopefully you're going to the emergency room for something emergent. And if it is something emergent and your doctor has documented, yes, this has been an emergent problem, then it's no problem. You just let your primary care know within 48 hours and the VA typically pays your bill.
And the good news for us, we had some challenges during the COVID period. Just for safety reasons, we had to limit the amount of beds and some things we did. And it did pose a challenge for us in getting people in timely for residential substance use treatment. Today, we can get you in. We have beds and availability, can get you in well under 30 days. We have availability even for emergent or urgent needs, and then for normal needs to get them in. And we've been doing that for quite some time. So I don't anticipate really many situations where we're not able to accommodate or serve people with residential substance use disorder needs.
Well said. Can't argue with that. Other than it sounded like you were pitching me residential treatment. Should I be thinking about residential treatment?
Well, not
been
you
there,
in
done
particular,
that.
not you in particular, but we have great programs, and I should mention one of the greatest days that I've had in quite a long time was about 3 weeks ago on a Thursday. I went to our domiciliary in Bonham where we have residential substance use treatment, and Thursday afternoons at 3:00 is their graduation day, their graduation ceremony, and it is an incredible experience. I was honored to be able to witness it or participate, but you get to, all the veterans in the program come together, even ones that are newly admitted, ones that are still going on in the program, but they honor those veterans who have completed either the early phase of treatment or a longer phase of treatment or getting ready to graduate and go back out into the community. And they celebrate each other, and then the veterans have a chance to share about what they've learned and to say thank you. One of the veterans wanted to do that through song. Others came back and wanted to share. He had left 3 years ago and had been sober for 3 years, came back and got his 3-year chip, but wanted to share with people about his life, and it was just an incredible experience. So we do have great residential treatment programming, and it's a wonderful experience to watch them on Thursday and participate in their graduation ceremony.
Yeah. I mean, it's always a great experience. I guess Christina Meek was out there, huh?
Yes.
Yeah,
yes,
of course.
Yes.
I know. Her and I are always we used to be in consistent competition. It's like a little joke. I know, sidebar, but we used to be in consistent competition with each other when we were peers, because I worked in Dallas, she worked in Bonham. We never met each other, but we were doing all these different like new things. And then I'd always do this new thing. And and then someone would be like, oh, you're doing such a great job because you're doing this new thing. And then like all of a sudden she'd do this newer thing. And I'd be like, dang it, who is this girl? Right? And so I got to meet her for the first time before she came onto the podcast. And I was like, I just want you to know you've been like my arch nemesis for like my entirety of my peer support career.
Well, both you in that role and her were outstanding peer specialists and do great work.
Thank you. I know I was a pain in your absolute butt, but I appreciate the kind
I
words.
Describe it that way.
All right, so let's talk about this. What if a veteran had a bad experience, okay, with mental health in the past? Why should they come back?
Yeah, I appreciate that too. I think that there's a couple things when you talked about kind of my role or what it's like to be the chief or to run the service. I want you to know that I acknowledge that those things happen. They can happen to any of us in a healthcare setting, and we deal with those. Sometimes they hurt worse when we're in a vulnerable place for mental health, and it doesn't work like we expected, or we're disappointed in the service we received. And we want to hear about those things. I need to be able to correct or handle or address those things. And I think, I've been here working here now for almost 16 years. Certainly, I feel like a lot has changed over that time in terms of how we present services, the things that we've been able to do. There's still things that we can do or grow or do better, but the environment is different and what we provide is different. And we have made changes and we have responded. We get a lot of information, as you know, about veteran surveys and their experiences about services. And then I really appreciate the veterans who are willing to go through a patient advocate, go through other channels, come to us and express concerns. Even through other channels, congressional offices or the White House hotline, all of those things. We take those, we respond to those. In my service, all of those responses come through me. I review them all. And that's partly because I have a commitment to want to make sure that those were addressed in a way that, if at all possible, is satisfactory to the veteran. And so I'm looking at that. Sometimes that is a discussion with the team to ask them to do one or two more steps to resolve or help in that way. But we want to address those things. So I really want to encourage or let them know that we appreciate hearing where there are challenges or concerns. We want a chance to make that right. And for those who it was a while back, we would love the opportunity for them to come again and give us a second chance. There are ways in which there have been a lot of improvements made, and I think they would find that.
So what's the best way for a veteran to, like, if they have a bad experience, what's the best way for them to kind of, I guess, I don't want to say complain, but share with us their opportunity for change, right? Is that what you would say? Share with us their opportunity for change, but in the most constructive way possible. Because I know as veterans, and we're running out of time here, so I got to speed this up. But as veterans, I know that we get opportunities, obviously, to go see a patient advocate, right? But a patient advocate is sometimes a hit or a miss. Let's just be honest, okay? I mean, it is. I mean, to be honest, as a veteran, to be transparent, it is hit or miss sometimes. Sometimes they solve it very effectively. Okay. Sometimes they do not. And so I guess, or do we have like we used to have the right to the director, right? To where veterans could do that. So is there a method or a methodology, or is it patient advocate?
Well, no, I think patient advocate is an option. I think there are veterans like yourself who, if you're comfortable, I think the right thing to do would be to, if, for example, if it is concerns about something that happened with a clinician that session, you might be one who's comfortable bringing it up right then or
1,000%.
saying something. Yes. And,
yes.
And that really is wonderful. That is a way in which they can address it. Oftentimes when I'm reading a complaint or something, we are making sure, is the clinician aware of this kind of concern, and give them a chance. I realize there may be veterans who don't have your personality, so it may be uncomfortable for them to do that. Oftentimes the right thing for them to do then is to, if they're already enrolled in a certain mental health team, just at the desk where the clerks are, to ask to speak with one of the directors, one of the leaders of the clinic. That's their most direct way, and they will get a message to that director. Most of the time that director is going to either walk out right then and take them back to discuss their concern or see how they could help, or is going to find a time to call them or see what happens. That way it is the person that's a directly supervisor over that team and has the chance to make that right. If they feel like that's not helpful, they can also call and just ask to speak to mental health service leadership. We address those in our office and take those complaints directly. Again, first thing I'm going to do is see, is the team aware of this concern? Have they had a chance to address
You're going to follow
it?
the paperwork trail.
Yeah, well, I want to make sure, obviously, for me,
lowest level
if
possible.
it's a concern about a treatment on a certain team, then I'm going to have to direct them to that team and the leadership who can solve or help them. If they've already reached that and they still have some concerns about that, well, of course, then I'm going to get involved and connect and see what we can do, or others on my team are going to do that kind of a thing. So really, the clinician that there's a concern about would be best, or the leadership on that team would be the next step. But then they can use any other channels. And the patient advocates do have a hotline to my office and other ways, know how to get in touch with me or connect if there is a concern.
Wait, they do have a number to your office?
So they message
That's
me directly.
crazy. I wonder why they don't use it. Yeah, I'm just kidding. They do a great job. Honestly, they really do. And I'm sure that they deal with a lot of different complaints. And so I'm sure that it's hard to sift through. So God bless them. Bless their hearts. All right. Well, listen, that's all we got time for. I know I had a whole bunch of other questions that I literally prepped you for, but I have literally out of time. Do you want to answer anything else?
I do.
Okay. Okay, go ahead.
I don't know.
You're the chief. You get to tell me what to do.
I don't know if it's through the future question. I want to say something about our suicide prevention program.
Go ahead. Yeah.
I know we were talking earlier even just about not only what is mental health currently doing, but what are we doing in the future?
Yeah, exactly. Yeah, that's what I said, okay, let's talk about some of the changes coming from mental health VA.
And so this kind of covers both for me. One of the things that I knew this question might be coming, so I didn't answer it earlier, but it is a prominent part of our current programming is our suicide prevention program. One of the exciting things for me, though, is we have a large expansion of that program. So we are in the process of adding an additional 11 staff, more than doubling its size for a number of reasons. Because we have a great need there, as we are the largest mental health service. We get a lot of veterans in our catchment area who call the Veterans Crisis Line. When that happens, there's a hotline provider that talks or works with that veteran, but if they're in our catchment area, then they reach out to us right away. And we have suicide prevention coordinators whose job is to reach out to that veteran, check in on them, and then coordinate mental health care if that's needed and follow-up care, make sure they get engaged or connected. We get a lot of those, so the volume is quite high. We want to continue kinds of things that I know are near and dear to your heart, which is partner with community providers and help in ways that we can reach. One of the things that we understand and why we were able to get this funding is suicide prevention is the highest priority in our VA, really, certainly in the Office of Mental Health Services and Suicide Prevention.
Across the entire VA, no matter what service you're in the VA, that's our top priority.
There's a lot that we do and talk about in our clinical care and addressing those things, but there has also been funding that's helping that. And for us, that is a significant number of positions. That's going to be more who can help and provide responses to veterans in crisis and get them connect and care. We have some specific positions now that are called community engagement and partnership coordinators. They are their design will be to be in the community to partner specifically with community agencies and partners exactly around suicide prevention efforts and training, those kinds of things. So we were engaged in outreach activities, but we're limited in what we could do because of the size of the staff and other demands. But we are about to expand greatly. We're in the process of hiring those positions now. I think the future for us is not just providing great care in the VA and helping veterans get access. Of course, when we treat those who need mental health needs, we do a lot for suicide prevention, but we recognize we cannot do it alone. We really have to have a public health partnership in this way and connect with community agencies, brainstorm together, talk about together, train together, and figure out what we can do. So we're adding we have a huge program there, but we're adding a large number of staff now, and we're going to see a greater emphasis and more that we can do in addressing suicide prevention.
Well, good for Laura down there.
Yes, exactly.
Good for her.
Exactly. She's a key part of that.
Yeah, she is. She's a big part of that. I will tell you that I would be remiss if we're going to talk about suicide prevention if we didn't talk about LGBTQ services then, because I think that those services are phenomenal, and I think that Dr. Holland DeGuire, who we've had on the show, we've had the pleasure of having on the show, I think he does an absolute wonderful job, and that is covered under mental health too. I mean, it's just what program isn't covered under mental health at this point? That's really the question we should all be asking ourselves. But yeah, I mean, the LGBTQ plus services for VA are awesome, especially here. Like, I don't know. He's awesome. I love that guy.
Yes, Dr. Christopher Hall
I love
McGuire,
him.
psychologist, was actually in training with us, and it's one of the great things I love. One of the things we do in mental health is a large training program. Psychologists, social workers, psychiatrists, who while they're getting their degrees, come in as residents, as fellows, and train with us. He's a great example of that. And what we love is they come and they love working with veterans so much, and what they do with our programs that they want to work with us. He's our LGBTQ Veterans Clinical Coordinator, and he has just done outstanding work, as you mentioned. So developed all sorts of things, kind of provide enhanced training for clinicians, not only in mental health, but outside of mental health, and being attuned to LGBT issues. They're actually even creating something now called an LGBTQ Safe Provider Directory, where we have clinicians all throughout the VA, in our VA, who sign up for certain trainings and education, take those education and trainings, and then are listed so that when we have veterans who call us with LGBT issues or concerns and want to be seen by a provider where they know it's safe and that who has received some training, those are in process. We have clinical consultation on a monthly basis where providers can join and get help if they want some guidance about addressing certain LGBTQ issues. We could go on and on with
I'm
the
sure.
kinds of things,
Yeah, I'm sure.
For employees and for veterans. There's therapy groups, there's support groups across the board, and we're very proud of what's happening there.
And I'm just going to plug this, just you're welcome plug. He's going to be hiring, lots of hiring. We lost a lot of people during COVID. Did we not?
Yes, I think that is a national issue. We've seen that everywhere.
Of course, yeah.
Not just in healthcare, but across the board. Even they talk about the Great Resignation, and we've experienced that too. People, because of the stresses we were mentioning, or ways, have made major life decisions, have been willing to make
major life
transitions
changes.
Yes, and so we've had a number of people decide to take other jobs or move when they weren't going to do that before, and that has affected us too. And we're struggling with that right now. We're going to get through that. We're working on things in terms of ways to enhance what we offer for people that we're interested in recruiting. We do have vacant positions. If you know of great social workers or psychiatrists, psychologists that want to work in mental health or with veterans, send them our way. USA Jobs, you'll find them posted there, and we're working hard to bring people on board and get those positions filled.
I would curtsy if I wasn't sitting down. You're welcome.
Thank you, Mike. I appreciate
You're welcome. No, I wanted to mention it because I know that honestly a lot of people always ask that, right? Is like, how in the world can I get a job at the VA? Or, hey, I know this social worker and she really wants to work with veterans. Most of the time, honestly, we're kind of closed up because we either don't have the funding right now, or we're going through some transitioning or whatever it may be, right? Or COVID, or I mean, who knows what the craziness is going on. But now it's a pretty good opportunity that if you are a clinician out there, a mental health clinician, and you're looking at wanting to work with veterans, honestly, now would be a really good opportunity for you if you're looking, especially in the North Texas area. So, usajobs.gov.
That's very true. Thank you.
I wish I had like a ding. Right? Well, listen, that's it. That's all I have, unless you have any parting words.
No, that's all for me. I really appreciate the time and the chance to talk about the service. Thank you.
Well, thank you. Thanks for being on. I know I'm not mental health's biggest fan. No, I am mental health's biggest fan. I know I'm not y'all's. I don't even know how to put it. I know I'm just like, I'm a bane of y'all's existence. So
I appreciate the ways in which you advocate. I think you are a big help to us, and I appreciate you came out of our service, did a lot for us there, and have continued to do so. I appreciate all that you've done to highlight Mental Health Awareness Month, and I think you're hard on yourself about that.
Oh, thank you. He's just on camera, y'all. No. All right, everyone. Listen, thank you so much. That's all we got for you for this episode. Huge thanks to Dr. Bender for being on and putting up with me for about an hour on this podcast. And yeah, listen, please take mental health serious. And if you're a veteran, please go seek mental health. There's nothing wrong with mental wellness. Go and talk to somebody. Go to one of these access clinics. Go to one of these primary care integration clinics. Ask someone to be connected with mental health. It's the right thing to do, and it's so easy. It's so easy. Okay? All right, so no excuses out there. Go and do it. And just remember, no matter how bad things seem to be, just Charlie Mike. At least I got something left to stand for.